Não conhecem isto? Não conhece isto, Berta? Pá, se não conheces isto, tens que ir ao e tens que ouvir isto. Estou? Tá? Está ok? Está ok? Já estamos com um ligeiro delay. Ok? Eu não sei se os ouvintes... Já estamos live? Ok. Não sei se os ouvintes também conhecem os nossos... Ouve-se bem? So, em inglês, não é? Em inglês for our fans in YouTube. So guys, welcome to the second season, second episode of What Would You Do in Clinical Case. So last week we had a wonderful presentation from the orthodontics, but today we're going to have implant dentistry, okay? And we start today with a classic by Mick Jagger, the Rolling Stones. Do you know this music? Do you know this music? What is more important than Mick Jagger and the Rolling Stones? What are you doing? Pay attention. Okay, so this is Mick Jagger and the Rolling Stones. You can't always get what you want. You can't always get what you want. You can't always get what you want. But if you try sometimes, you get what you need. Okay. So this clinical case, it's about you can't always get what you want, but sometimes you get what you need. So welcome to What Would You Do session. So we posted on the internet, on Instagram and on YouTube Live and on Facebook and on Threads and on LinkedIn and at every social media, WhatsApp. We send the WhatsApps, emails. We send everything with this clinical case. And I ask you, please help me. What should you do in this situation here? This is a typical extraction that was made a long time ago. And now we have a soft tissue defect and a hard tissue defect. And I ask you, what would we do? And don't forget to click on the bell on our YouTube channel and follow our content, okay? Follow our content on YouTube. And so the clinical scenario was, well, I need this gentleman to have 2 teeth over here. You know, he came to the clinic and said, listen, I need 2 teeth. Can you help me? So we did a CT scan, we did all our clinical evaluation, and then I posted you these couple of cuts so you can see, you know, the bone availability, and I show you the 3D image of more or less what he has in the mouth. And so the question was, this is a young male, 41 years old, typical 2 extractions, but he had some systemic diseases. You know, he had a autoimmune disease, and he's not heavily medicated with immunosuppressors, but he's medicated with immunosuppressors. So that means that on the immunological level, we have something different from a normal patient. And of course, he wants to rehabilitate the first quadrant. So the statistics of the 1,000 answers that we had was 30% of you did implants and guided bone regeneration at the same time, okay? It's a wonderful option. It would be, you know, in the majority of cases that we present with this defect, it would be my option also. 21%, no, sorry, it was a mistake. Yeah, I made a mistake, okay? 30% of you voted we do guided bone regeneration first and then wait and then place the implants in the second appointment, okay? This is 30% of you. 21% of you would choose, let's do both at the same time. Let's do guided bone regeneration and implant at the same appointment, same surgery. And the majority of you voted that we should first correct the soft tissues, 1 surgery, then we should wait and do a guided bone regeneration, it's a second surgery, and then wait and then enter to place the implants in a 3rd surgery, okay? 3 surgeries for 39% of you. And 9% of you would say, just place the implants and finish the case, okay? All right, so that means that 90% of you, 91% of you would definitely go for guided bone regeneration and implant dentistry. Well, Like I told you when we were doing the teaser, there's not the correct answer. There's the option that we did, that is probably not the option that you did. It's probably not the option that is correct, but you have to, have in mind not only the literature, but also the patient that you have in front of you. And don't forget, this is an autoimmune patient that we have over here. It's not a completely heal-free, disease-free type of patient. We have an autoimmune disease with immunosuppressors. So that means that all the immunological system of this patient is not working as it should be. So there are a couple of items and a couple of features that you have to bear in mind when you're going to do an implant-supported rehabilitation or an oral surgery procedure. The first one is that the patient, every time that he extracted a tooth, he had an infection, okay? So when it comes to you, he already did some surgery in his mouth, and for sure the last thing that he wants is to have major infections in surgical procedures that we have in the mouth. So the first thing that we'll ask you is that, is implant dentistry safe? Okay, and we said, well, it's not bulletproof. No, you have some predictability with dental implants. And the second thing that he asks is, do implants produce an immunological response? Okay, because I'm lacking that response. And what we have to say, yes, dental implants produce an immunological response, okay? Titanium, metals, they produce a response. Ceramic also produces a response, although lower, and PEEK and PMMA produce an immunological response. So he's trying to avoid that. Plus, when we said to him, okay, let's do guided bone regeneration, he said, okay, what type of material are you going to use? Okay, for someone who's immunocompromised, these questions and these decisions are very important, because are you going to use a xenograft? Are you going to use a xenograft as guided bone regeneration? The first thing you will say, if I cannot tolerate my own body, I cannot tolerate the cow. And you say, okay, so let's use autogenous bone. And he says, okay, but maybe I heal okay, maybe I don't heal okay. And so if I have a second surgical site, I'm increasing the mobility. And he said, okay, so let's use an allograft from a cadaver, from another person. He cannot tolerate his own body. So if you're going to place something from another body, the chances that you're going to have an immunological response towards, let's get rid of this material is very high. So let's go to the facts. The fact is that, okay, by my experience and judgment and by the evidence-based research, I would do guided bone regeneration and 2 implants with not a question, okay? But this time, we have the patient's preferences or value that we have to combine these to get an answer for this patient. It's not just what we know and what would be our major surgical expertise, it's also about the patient. So you have to think about the patient, always think about the patient. Think about the patient. Always think about the patient, okay? Think about the patient, even in orthodontics, okay? Think about the patient. So let's go to the facts. Do I have bone to particularly place 2 implants here? And the answer is yes, I have. I mean, going to the literature, if I show you the 8mm implant tissue level on the molar, is there any contraindication to place the implant all alone? No. I have bone, I have height, I have width, I have a solid implant, so there's no problem. The Klaus-Lang literature about the 2mm of bone, buccal and lingual, I have it. So there's no contraindication. There's bone to place the implants. There's going to be also integration, okay? On the premolar, do I have any contraindication to place the implants? No, of course not. This is a 4.1 implant, and I still have 2mm of bone, palatal and buccal. So there is no contraindication to place the implants into bone. We have bone, so we don't need guided bone regeneration for osseointegration, okay? So there's one step down. So the other part is, what about the soft tissues? Yes, here I have a problem, okay? It seems that on the buccal side, I don't have keratinized tissue. I only have mucosa, okay? And then if you go to the dichotomy between keratinized tissue and soft tissues and mucosa soft tissue around the dental implant, it seems in fact that it's better to have keratinized tissue that don't have keratinized tissue. Although the type of implant would also interfere on the outcomes of this dichotomy, okay? But I sure myself prefer to have keratinized tissue around the implants, and it's a fact that we don't have it, okay? So I kind of understand those of you who place, let's restore the soft tissue first, then do the guided bone regeneration, then the implants. The option is correct. I mean, we can do this in this stage, but the downside of this is that you're doing 3 surgeries to this patient, okay? 3 surgeries on a patient that already knows that he's gonna heal very bad, okay? So soft tissue grafting and other type of material is also a risk for these patients, okay? So is there an option to contour this problem? Yes, surgical manipulation of the fact, okay? So imagine this. Play with the macrogeometry of the implants instead of playing with the guided bone regeneration. You don't get the same outcome, okay? Guided bone regeneration allows you to produce much more bone in volume. But for this kind of patients, just produce what is necessary so we can receive crowns, to have teeth so we can bite, okay? Don't forget the outcome, the aim that we're trying to have. We want to have teeth, okay? He doesn't need implants. The implants are a mean to get the teeth, okay? So if the bone is okay, the only thing that we have to try to correct is the soft tissue. And that you can do with surgical manipulation of the area at the time of implant placement, okay? So if you go a little bit more palatal and you place supracrestal type of implants where you can have, you know, a wide platform so it holds the tissues while they're healing, then you can have a different type of approach, meaning that you can manipulate the keratinized tissue on the buccal side and still have a minimal correction of this problem. So now what you're seeing is that I'm placing the implants towards the best prosthodontic position within the house of bone, and I'm correcting the soft tissue by manipulating the tissue to the buccal, okay? So this is very important. Obviously, the ceramic implant also plays a role in here. It's not the objective of this lecture, but the immunological response will also be lower with the ceramic implants. And after having this discussion with the patient between titanium and ceramic, he decided to have ceramic implants. And if you have the indication to have ceramic implants, then it's a green light, like it's in this case. And so we place the 2 implants over here. This is a pure ceramic 4x10. This is a pure ceramic 4x8 in the first quadrant position. And then when the patient comes back, you see the healing, okay? Just by surgical manipulate the area, okay? It's not like the perfect guided bone regeneration that we wanted to have, that we wanted to get, but sometimes we get what you need, right? That's a Rolling Stone music, okay? So in this case, you see there's an improvement, not a major improvement, but there's an improvement on the profile and then a soft tissue defect that we had in the beginning by having, you know, a supracrestal tissue level type of implant that's pushing the tissues forward in a supracrestal position, okay? It's not a major improvement, but is the enough improvement so we can receive 2 crowns over here. Now, implant dentistry is a discipline. For me, it would be a specialty on their own. It's no perio, no prosto, just implant dentistry, okay? I can say this now, I don't have anything to hold me back. Implant dentistry should be a specialty. Why? Because the work does not end here, okay? This is not like perio, you send it to the prosthodontic guys and the prosthodontic guys just restore the case. No, 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 no. It's a lot of work between prosto and surgical field, because now you are going to have to do crowns in a different way. You're not going to put 2 big molars over here. Why? Because he needs to have a good cleansability of the area. He needs not to have food entrapment, so he needs to work and function well. So it is obviously that in these cases, you need to do individual crowns like we did, not a bridge, do not do a bridge, you know, let the dental floss go. They hold, that, you know, single implants, they hold. You don't need to ferrilize implants. You need to do rehabilitate spaces so the patient can clean properly. And in this case, with an autoimmune response that is lower, you need to clean, okay? So in this case, We send it to the prosto, and the prosto will obviously do contours that allow this short space to be cleansable and to be completely, free of stocking food over there. So you have to change the way that you rehabilitate in these cases, because you don't have, a lot of bone and a lot of tissues outside. So what you reduce the tooth to have more or less the size of the tooth exactly to the occlusal table, okay, which is very distant, occlusal table and palatal lingual position of the tooth, okay? I spent 10 years trying to reach that concept, okay? Because university, you never understand what they're talking, So you reduce the size of the tooth to basically to only have the occlusal table present, okay? So it allows you for the patient to be completely comfortable, okay? And you can see on the buccals, on the vestibular side, you have to be very careful on how these supracrestal tissue levels end. So it's a different philosophy than the subcrestal one and intermediate abutments. So this is supracrestal implant with a crown that has to be made and tailored for this type of implant, okay? And then you finish the case, okay? And you finish the case and you see, let's go to the facts. Do I have implants into bone? Yes, I have. Do I have keratinized tissue around the implant? Yes, I have. Do I have a major contour and a major correction? No, but is it sufficient for this patient to have two wonderful teeth that are function well and that are completely integrated in the smile of the patient, okay? So to wrap it up, okay? When we ask these questions, obviously you can do all of them, okay? They are correct, they are indicated. You are trying to answer each problem that you found on the picture. But when you see the whole picture and you see the facts that we have, we decided to go for just place the implants and restore the case, okay? That was the most simple and effective technique, and not to do any over treatments that in this particular patient are totally unnecessary, okay? So the implant, the 9% of you that vote on the implant, that was our choice, but doesn't mean that the other ones are wrong. So, thank you very much for this wonderful morning. Next week we're gonna have prosthodontics, and I'll see you there.